Chapter 39, Part 1, Alterations in Renal Function. I'd like to thank the Elsevier Corporation for their slides. They're great, and that's what we're using in this presentation. And I recommend the Pathophysiology 8th edition of McCann's and Urita's book. It's an excellent book. Okay, so this is horseshoe kidney. It's fused at lower poles, and you can see it's kind of adhered together. Normally they'd be down in a dependent way, and it kind of shows this is the kidneys on top of the bladder, and kind of a distorted picture, but that's a horseshoe-shaped kidney. And these are some of the pathology you might see as adult polycystic disease. You see multiple cysts in the transected kidney, and this is what it looks on the outside. And this is a pediatric version of infantile polycystic disease. So urinary tract obstruction, blockage of flow of urine within urinary tract. Obstruction can be caused by anatomic functional deficit. The important things are location, completeness, and involvement of one or both kidneys, duration, and the nature and the cause. You really have to ascertain the cause because many times it can be quite serious, such as in a woman with ovarian cancer. So we have upper urinary tract obstruction. There's the complications are hydroureter, hydronephrosis, uterohydronephrosis, dilatation of the renal pelvis or the calculi, and it leads to excessive cellular destruction and death of the nephron. Nephrons are the unit within the kidney that actually control the flow of body fluids. So this compensatory hypertrophy and hyperfunction occurs when there's a negative consequence of unilateral obstruction, and there's obligatory growth and compensatory growth. Post-obstructive diuresis is caused by relief of the obstruction and may cause fluid and electrolyte imbalance. So they can put out quite a bit of urine after. That's one of the ways you know that the obstruction has cleared, actually, unilateral obstruction. This is a diagram of some of the possible obstructions. For instance, you can have a uropelvic valve problem. You can have a uropelvic stricture, fibrous bands, stenosis. You can have cancer, the transitional cell cancer in the bladder, the dome of the bladder. You can have a pregnancy that's pressing on the ureter. You can have endometriosis, carcinoma of the cervix, ureteral stone, blood clots. So any number of things can cause it, and this would be a radiograph picture with dye contrast study showing the obstruction here. You see hydronephrosis here, and you see hydronephrosis here because on both sides it's backed up. As urine tries to get here and out here, it can't get out. So you can see that this is an issue. And that's why it's so hard to know. So you really have to figure out exactly what's causing the stricture or the obstruction. This is a picture of hydronephrosis, marked dilatation of the renal pelvis. And here's another one. And this is a picture of a hydroureter in a woman with ovarian cancer. So kidney stones, also called renal calculi, are one of the major problems you see in primary care. Masses of cysts, masses of crystal, protein, and mineral solids form in the urinary tract and may obstruct the urinary tract itself. Risk factors are male, mostly before the age of 50. Inadequate fluid intake is one of the most prevalent causes, and geographic location. So the composition of kidney stones are mainly of mineral salts, and calcium oxalate and calcium phosphatate make up 70 to 80%, and struvite or magnesium, ammonium, and phosphate make up 1 to 5%. Uric acid make up 5 to 10%. Genetic disorders of amino acid metabolism can be a cause of some of these kidney stones, particularly the cystinouric and xanthine stones formed in the presence of low urine pH. The biggest kind of stone you're going to hear about or see is called a staghorn calculi. It's large and fills the major or minor calyces. Non-Staghorn calculi vary in size and location depending on the size and what the material they're made of. This is some pictures of them. Calcium stone is looks like a kind of a pebble. The uric acid stones are quite irregular. Struvites are irregularly shaped, and cystine stones also irregularly shaped. The kidney stone formation is a supersaturation of one or more salts in the presence of salts in higher concentration and volume able to dissolve the salt. So the precipitation of salts from a liquid to a solid state, temperature and pH. Growth into stone via crystallization or agglomeration. So this is the forms of matrix. Kidney stones have presence and absence of stone inhibitors. Alkaline urine inhibits increase the risk of calcium phosphate stone, and acid increases the risk of uric acid stones. And magnesium citrate and other type of substrate can cause stones. This is a picture of a staghorn stone, and you can see it's quite large. This is the renal tissue, and there's these big stones filling the kidney. These are some radiographic films to show you how you find them. Many people use an ultrasound, particularly in the emergency room. It takes a little, sometimes be hard to diagnose them from that because there could be other causes, but this is the most standard way. You get a KUB, is called the kidney, ureter, bladder, X-ray. It's an AP view, and if there's a kidney stone, it'll appear in this white kind of round-shaped substance. It's usually a calcium stone, are easily seen. So calcium or phosphorus stones you can see on X-ray. This is a picture of an IV contrast, outlines the drainage of the kidneys. This is the kidneys or the pelvis, and then you see the drainage of down the ureter. And this is a picture of a non-contrast CT with a stone in the ureter. Just it says non-contrast. If you had a contrast study, if you use contrast, oral or IV, but IV in particular, you would not be able to see this because the blood vessels, which are right here in the aorta, and bifurcation of the aorta and other blood vessels would be filled with this white substance that makes it look white and dye substance, and on X-ray, on CAT scan. Clinical manifestation, the biggest problem is pain. If you have to manage pain, it does usually require narcotics. This is quite painful, and sometimes people can tough it out, but they know people who've had recurrences, they particularly come in the emergency room and tell you exactly what's going on. Adjust the pH of urine, decrease the amount of stone-forming substances, and removing stone from percutaneously with nephrolithotomy, ureteroscope, ultrasound, or laser lithotripsy, which fragments stones for excretion. Neurogenic bladder is a problem that affects many people, particularly as they get older, but also after injuries. Bladder dysfunction caused by neurological disease is a problem with urine storage or voiding. There's two types, upper motor neuron and lower motor neuron. Remember when we talked about this when we went over upper motor neuron and the lower motor neuron? So upper motor neuron causes dysenergia or overactive or hyperactive bladder, whereas lower motor neuron causes dystrusa areflexia. Important to keep in mind because if they have retention or areflexia, hypotonic, atonic, then it's probably a lower motor neuron. If they have overactive or hyperactive bladder function, then it may be an upper motor neuron. Usually upper motor neurons are usually related to spinal cord injuries, tumors in the spine, also brain tumors. A clinical manifestation of the lower urinary tract obstruction is frequent daytime voiding more often than every 2 hours while awake, nocturia, nighttime voiding, urgency, often combined with hesitancy, dysuria, poor force of stream, intermittent stream. So treatment is in detrusor sphincter dysarthria with alpha adrenergic blocking agents, alpha blockers. anti-myriskin drugs, and they also use botulism injections. It seems to work quite well sometimes. Sometimes you have to use intermittent catheterization with higher doses of anti-myriskin drugs. Condom catheters will work sometimes for men. It's supplemented by alpha-adrenergic blocking, or TURP, or transurethral sphincterotomy. So obstruction is treated with medication and bladder neck surgery. Treatment of low bladder wall compliance, anti-myriskin drugs, intermittent catheterization, severe augmentation sometimes required with the enteroplasty. A person has a lesion in the lower neuron that involves the sacral micturition center, which consists of the person experiences. So it's the lower motor neuron, right? So remember we talked about dyssynergia, which is the hyperflexia side, right? And so it's going to be number one, detrusor areflexia.